Good morning, everyone. I know it is early, but I see we have a full room. Before I get too excited, let me make sure you're all in the correct workshop. This is maximizing quality by improving clinical documentation. Okay, well, since no one is making a mad rush for the exit, I will assume you're in the correct room. My name is Dr. Colette Morgan, and today I'm excited to get to present to you a topic I'm very passionate about. I have the pleasure of teaching clinical documentation improvement throughout the country to doctors, NPs, PAs, nurses, CDI staff, coding staff, office managers. And no matter what group I'm addressing, one question seems to continuously come up, and that is, how did I get involved and interested in this to begin with? Well, actually, my interest began back in 2004. At that time, I'd finished residency and I was in private practice. I spent 5 years in private practice doing both inpatient and outpatient. And during this time, I served as utilization management director. And it was the first time I saw the administrative and billing side of medicine. As a doctor, I was astounded at how much of what I charted was completely lost in translation. I became painfully aware of how often our patients' charts fail to show just how sick they are, simply because our documentation did not capture it, and how much this significantly affected quality metrics and reimbursement. It was very clear to me that my residency training never taught me how to speak this behind-the-scenes language of medicine. So let's take a look at our objectives. Certainly you can read them here on the slide, but I can assure you that we will not spend the next 2 hours going over codes and billing terms ad nauseum. Now, while there is some basic background information we need to cover to aid in understanding the importance and the logistics of clinical documentation, we will go ahead and get that out of the way early. The bulk of our time today will be spent going over practical examples and guidance for the common diagnoses that we all see on a daily basis. Now guys, truly one of my greatest joys is when I'm able to help a provider reach that aha moment. And that's the moment when all these technical terms of billing and coding merge with the reality of our clinical language. So let's get started learning how to write it right. So here's a list of some of my favorite quotes from my colleagues over the years regarding clinical documentation and the infamous documentation queries that we receive. Listen, please feel free to jot down any additional quotes on your evaluation forms so that I may add them to my growing list. So why should I care? I am a doctor or APP, advanced practice practitioner, not a coder. This is just to help the hospital get more money. It won't help me. Whoever reviews these charts obviously is not a doctor, and I will not waste my time answering to them. If I know, I will tell you. I don't have time to go back over a note I wrote 4 weeks ago. Just look through the chart. As a practicing provider, often working 7 consecutive 12-hour days myself, I understand the frustration behind these quotes. But hopefully today, we can give you the knowledge to overcome these frustrations. I say that because one thing I've learned over the years is that once you learn how to document your common diagnoses properly, it becomes habitual and queries decrease significantly. So this is the challenge we all face. The physician or advanced practice provider is the principal supplier of the documentation in the medical record. All coding and billing of the medical record is dependent on this documentation. The conditions must be clearly documented in the record by a licensed treating provider. Coding and CDI staff cannot make clinical assumptions that a condition exists. I cannot stress this point enough. So one of the examples that come up quite frequently, you write in the chart, sodium 120 will start patient on normal saline at 125 mLs per hour and will recheck electrolytes tomorrow. I understand as a clinician that patient has hyponatremia. I see the lab value and I see you're treating that. However, as a coding and CDI staff, they are not allowed to code what we do not document. And all you just documented was a lab value, not a diagnosis. Very important point to remember. As healthcare providers, we're often trained to document patient care using clinical terminology, symptoms, radiological and laboratory data, and even our orders. However, on the other side, coders use the terminology set forth by ICD-9, CPT, and something many providers aren't even trained on, DRG/MSDRGs, which requires specificity and diagnostic statements. Now let me pause here for a moment because I would be remiss if I did not mention the major change coming October 1st, 2014. As many of you are aware, the United States will change over from our current ICD-9 with approximately 13,000 codes to ICD-10, which will have approximately 68,000 available codes. This is going to be a huge change. Now, I do offer ICD-10 workshops. However, it is extensive training and is outside of the scope of today's lecture. So while we won't cover ICD-10 today, you may occasionally hear me reference how some of our current documentation will be affected by ICD-10. So let's restate the problem. Healthcare providers document one way, the language that coders use is totally different. And these two languages, unfortunately, are not synonymous, and they often don't translate well. Let me give you a common example. Hypertension. If I write hypertensive crisis, as clinicians, we think of a patient with markedly elevated blood pressure who may even eventually require IV medications to control their blood pressure. However, when a coder sees hypertensive crisis, that codes out to the diagnosis hypertension not otherwise specified. Along the same line, I used to often write hypertension uncontrolled to represent a patient whose blood pressure is elevated and I'm actively adjusting their medications to try to get better control. Well, imagine my dismay when I found out that ICD-9 doesn't even have an uncontrolled code for hypertension. So, of course, my question, well, what are you coding? Once again, every time I wrote hypertension uncontrolled, it coded to hypertension not otherwise specified. So in both instances, we had a sicker patient whose blood pressure required us to actively manage it, but the translation in billing never reflected this. So one of my goals today is to help you realize and avoid some of these common clinical documentation pitfalls.